My name is Elaine Ziemba, and I'm the Vice President of Risk Consulting for the Risk Authority at Stanford and Administrative Director for Risk Management at Stanford Medicine. Welcome to our live webcast entitled Communication and Resolution Programs, The Voices of Experience. Let me set the stage for today's webcast. Today we will be discussing the current state of knowledge and experience which has evolved from the work of early adopters of communication and resolution programs. What have we learned from the efforts and experiences to better equip and inform others who wish to develop communication and resolution programs at their healthcare organizations? In communication and resolution programs, or CRPs, health systems and liability insurers encourage disclosure of unanticipated outcomes to affected patients and proactively seek resolutions, including offering an apology, an explanation, and where appropriate, reimbursement or compensation. Communication and resolution programs promise to promote a culture of safety, reduce liability costs, and provide a vehicle for disclosure and healing between patients and providers after an untoward event. In this live webcast, we will bring together three leading voices in the CRP field to discuss the following questions. Have CRPs delivered on their promise? What do the data show? And what best practices, if any, have emerged? And lastly, what challenges need to be overcome and what resources are available to healthcare organizations looking to embark on the CRP journey or strengthen their current program? I'd like to introduce our three expert panelists. Our first panelist is Leilani Schweitzer. Welcome, Leilani, and thank you for being here.
Thank you. I'm happy to be here.
Leilani has worked on Stanford CRP for the most recent 4 years. As a mother who experienced the loss of her son due to medical error, she has firsthand experience dealing with the challenges of CRPs. Again, welcome, Leilani. Our next panel member is Dr. Mello. Michelle is a legal scholar who is professor of law at Stanford Law School and a professor of health research and health policy at Stanford School of Medicine. Welcome, Michelle.
Thank you.
Rounding out the panel is Dr. Tom Gallagher. Tom is a physician who is also professor in the Department of Medicine and Bioethics and Humanities at the University of Washington and Associate Chair for Patient Care Safety, Quality, and Value at the University of Washington. Welcome, Tom.
It's a pleasure to be here.
I now look to Leilani Schweitzer to address the patient perspective toward CRPs. Leilani, from a patient perspective, how might CRP enhance the trust between patient and providers and their organizations?
Thank you, Elaine. So I think it's important for people who are thinking about CRPs to remember that patients are completely unfamiliar with this. They don't even know what this means until something very challenging and difficult has happened to them. No one goes into a hospital expecting the unexpected to happen to them. So if that does happen, their trust in the institution, the hospital, maybe their physician, that trust is damaged if it's not destroyed entirely. I feel like can be great benefit from acknowledging to patients that their lives have been impacted completely, or maybe just a little bit, but nonetheless, they have felt the impact of a medical event. When my son died, his death was complex, and the aftermath of it impacted many, many lives. One of his nurses who took care of him, she's no longer working as a nurse. One of his neurosurgeons, he quit practicing medicine as well. So the impact of these events go far and wide. I think there's a lot of value in being transparent with patients about their experiences. And what that really does is it tells the patients that their experiences matter and are valued. And that can be the beginning of a way to start to rebuild that trust that's been destroyed. And I say beginning because I think it's helpful to think of CRPs, the communication and resolution component of it, as it's a conversation. It's the development of a relationship. It's not typically a single conversation. And most patients, they won't be familiar with the process of reviewing medical care. They'll be surprised at how complex it is, probably surprised at how much time it takes. So for a risk manager who maybe has a demanding caseload, which is probably frequently what happens, for them, weeks or maybe months is a drop in the bucket. But if you're a patient who has experienced something in their healthcare, that can be a very long time to spend wondering what's going on. So that's why that communication is really, really important, to not leave patients wondering about what's going on. I also believe it's very important to help set expectations for patients. That's more conversations, that's more discussions. And again, those conversations are moving towards rebuilding trust. Also, patients, they don't experience a poor medical outcome in a context of maybe what we'll discuss today, of tort reforms or government regulations or legal precedents. For patients, it's a singular experience. It's very personal. It's a very intimate event. And for most patients, after an unexpected outcome, they want three things. They want an apology. They want the dignity of an explanation of what happened to them. And I hear this again and again when I talk to patients. They want to see improvements to ensure that what has happened to them never happens to anyone else. Being transparent and setting expectations, I know that this is challenging for institutions. I recognize that there's many concerns, and often I think someone wants certainty, so maybe the institution, they want to know everything before they start that conversation with a patient. And I think also, unfortunately, there can be maybe a thought that if we start talking to patients, that means we're admitting liability and we're writing a big check. That's a 1, 2, 3 proposition, and that's a dangerous assumption. Communicating with patients is not admitting guilt. It's a dangerous thing to think that way, because doing nothing, not communicating with patients, not talking to them, is really doing a lot. Saying nothing is leaving patients to answer their own questions, to find their own answers, to seek out information that maybe is not accurate. It's putting a lot of obligation on patients when they're in a very vulnerable state. And patients, they really come into these programs at a baseline of distrust and uncertainty. So that's where they're starting down here. And not communicating early and often, it's missing an opportunity and what I feel is an obligation to build trust with those patients. Here at Stanford, in our Pearl, we call our CRP program Pearl. And the great majority of the care that we look at through our Pearl program, we determine that the standard of care was not breached, fortunately. The care could not have been improved, and what happened was not preventable. And I really believe in those cases, having trust with those patients is even more important, because we're asking them to believe that we did a fair review, that we did the best we can. So if there isn't a background and a relationship of trust there, that can be a really difficult thing for patients and their families to understand and to accept.
Leilani, you make several good points, and I just want to address the panel on these 2 points. Number one, you mentioned that sometimes just having information is resolution, answers to questions or uncertainties. Michelle, I'm wondering if you could address that. CRPs are not solely addressing compensation and reimbursement, that sometimes resolution takes a different turn.
Yeah, and that's a really crucial point, and it's something we found over and over again when we've looked at different institutions that have tried this approach. Empirically, we find that between 2/3 and 3/4 of the events that are processed by these programs are events where there was not a standard of care violation. But those events are the most likely to be overlooked by institutions in terms of their communications with patients. They feel satisfied that they did their best, and for many institutions, that's the end of the story. But of course, as Leilani points out, many of these patients go home hurt and confused and quickly angry and seeking answers from outside parties that can lead to litigation. So addressing those events outside the event in which you have a patient or family who's angry in the hospital can be just as important in preventing the needless expenditure of funds and defense costs as quickly settling cases that do involve a standard of care deviation.
And Tom, from the physician perspective, is there a reluctance to have those types of discussions or openness with patients at the fear that that will then trigger compensation?
Well, it's one concern, but I think for physicians, the much more important barrier is that, when care doesn't go as expected, it's really profoundly embarrassing for physicians. It's uncomfortable. We really strive to deliver the best possible care all the time, and it's really overcoming that sort of fear of having an awkward, disappointing conversation that I think stops more physicians than the fear of compensation.
Thank you. And Leilani, just on a crucial element, the trust. How does a patient or family recognize or develop the trust that eliminates the fear they've been taken advantage of or are in an uneven bargaining position?
It's difficult, right? For everyone who's involved, there's somewhat of a leap of faith that we need to trust each other. And for patients, they're really between a rock and a hard place. Yeah. It's not like there's an easy option for them. A legal option, that's always there, but that can be time-consuming and expensive and very emotional. Or there's the need to trust in CRPs, or hopefully that they even have the opportunity for that program to exist. But the baseline, again, for patients, it's a tough spot for them. So it's not like hiring their lawyer and going that road is something that anyone particularly wants to do either.
I was just going to say there may be roles for lawyers outside of bringing litigation, and it may not be reasonable, particularly in a case of serious harm, to expect a patient just to place their trust in the institution and to trust that the offer is fair. I think many institutions who have operated these programs successfully have developed rosters of attorneys that they believe are highly qualified and who will give patients a fair assessment of the offer that's on the table and perhaps help them negotiate the offer a little bit without, in many cases, expecting to take home a third of an award that's already on the table when they come to the case. A group that I'm working with in Massachusetts, for example, has worked with the local bar association to identify attorneys that are interested in interfacing with hospitals and patients around this process. And that can also be helpful in bringing an independent evaluation to bolster a sense of trust and fairness.
Tom, comment?
It's really the transparency that's foundational to developing that trust. And I think organizations don't realize how easy it is to lose that trust and the implications of that. When patients and families think that there's a cover-up, it's almost impossible to rebuild that trust. We've had situations where organizations at that point have given the patient and family the entire medical record, and the question is, well, what pages did you take out? And so without that transparency, you really can't develop that trust.
Thank you. I'm going to move to the next polling question. What is your organization's attitude toward developing a CRP program? So as the results indicate, the majority are attitudes about developing a CRP program really hedge around exploring the possibility and open to the idea, but skeptical. Does this surprise you?
No, not at all. In fact, the first paper I ever wrote about these programs called this an improbable risk management strategy, because everything we know about malpractice claiming suggests the problem is not that there's too much, it's that there's too little relative to the prevalence of injuries that occur in the hospital because of negligence. So why would a program like this work, and does it work? That's a question that's occupied me as a researcher over the last several years, and I'd be happy to share some of what we and others have learned about this. It's important to recognize the data are still at an early stage in their maturity, but one of the best and most, I think, reliable reports we have comes from one of the earliest adopters of this approach, and that's the University of Michigan Health System, where Rick Boothman and others picked up this approach and really ran with it. These data are especially valuable because they were peer-reviewed and published in a very reputable medical journal, the Annals of Internal Medicine. And as a scholar of legal reform, I must say that the results are really nothing short of astonishing. What this institution was able to achieve in terms of bottom-line financial results, as you see here, is really just staggering. When they looked at the period after they implemented this program compared to the period before, they saw their rate of new claims go down dramatically from 7 to about 4.5 for every 100,000 patient encounters. The median time between getting a claim reported to the institution and resolving that claim also decreased significantly. And it's remarkable because this institution was already resolving things very quickly. The median time nationally is about 3 years. They got that down under a year. And patient compensation costs decreased dramatically, especially in the cases that actually became lawsuits. So even when this program wasn't successful in halting an incident from becoming a lawsuit, they were nevertheless successful in building enough of a relationship with patients to reduce settlement costs. And part of this, again, is trimming the time to resolution. The longer a case drags on, as everyone knows, the more expenses get puffed up into that ask. Finally, they were able to reduce their legal expenses significantly, and this was really the impetus for them adopting the program in the first place. The lawyers asked, why are we spending so much time and money defending cases that aren't defensible? So after this paper came out, I think institutions nationally were very justifiably asking the question, how do we get on this deal, and is it replicable? And that's a little harder to assess at this stage. The data are a little bit less clear, but here's what we have heard so far from other early adopters and later adopters of the program. We have two reports, one here at Stanford from Summit and the other from University of Illinois at Chicago. Both of these programs resemble the Michigan model in key respects. At the University of Illinois at Chicago, their internal report is that they were able to dramatically increase the rate of adverse event reporting. Now, most likely that's not because the hospital became less safe, but because they were able to foster a culture of timely reporting to risk management. They did see their rate of new claims drop dramatically, about 50% over the same period. And the median time to resolving those incidents, also dramatic reduction from 55 months, nearly 5 years, down to 1 year. So these, again, when you think about what we have been able to achieve with public policy reforms like damages caps, these results are just orders of magnitude more impressive. And the most recent data here from Stanford, which was compiled by their independent actuary, and again looked at a pre-post type of comparison within the same institution, also found dramatic reductions in the frequency of lawsuits, about a 50% reduction, about a 40% reduction in what was paid among the cases where some payment was made, and a 20% reduction in defense costs for cases that were handled through the CRP as compared to the traditional approach. So, can other institutions get these results? That's the big question. And the federal government has made a significant investment recently in trying to find out. They funded a variety of 3-year demonstration projects testing this approach in other settings. Non-academic medical centers, places where the physician and the hospital might have separate liability insurance, commercial liability insurance instead of a captive, where the physicians aren't employed by the hospital and might be harder to control, or where multiple insurers might have to cooperate to resolve a claim. Finally, it's been tested in areas that don't have strong tort reforms and where physicians really live in much greater fear of liability. And the results of these projects, I would say, are mixed in terms of what has been achieved. The areas of success, I think, primarily lie in the realm of communication. That when we have tried, for example, to roll this out in 5 hospitals in New York City and in 6 hospitals and multi-specialty physician clinics in Washington state, there were significant successes in increasing internal reporting of adverse events, improving disclosure practices. For the first time, many of these institutions developed a mechanism to ascertain whether disclosure was actually carried out and that it was a meaningful conversation. In many of the hospitals, stronger relationships developed between the clinical staff and risk management, which improved the risk management office's ability to intervene early and effectively when adverse events occurred. And in Washington, where we tried to get multiple insurers to cooperate, some of the partners were quite successful in improving their relationships, others less so. And finally, these projects got the institutions to greatly expand their radar screen in terms of the kinds of events that they were actively tracking. Whereas before, a risk manager in these settings might typically just triage out the most significant harm events and or the cases where a family was angry and complaining. This program led them to put all reported events, at least initially, on their radar screen for some type of cursory investigation and follow-up, and then triage and decision-making about what additional steps were to be taken. And I think one exciting development in a lot of these hospitals is for the first time, the risk and quality or patient safety offices began having conversations, would develop Monday morning meetings where they went through cases together to decide what next steps had to be taken and to ensure that those steps had been taken and that appropriate communications were made with families. So for many institutions, although these sound like simple things, they were very big innovations that I think substantially improved the environment of transparency and follow-up with patients. I think where some of the projects were less successful is on the compensation end. So I think what we were able to do very well is enable institutions to more effectively screen and identify candidates for early settlement. The types of cases that had kind of always been in mind for them as the cases they should be settling, but for one reason or another, they hadn't been very effective in doing that. What was harder was ensuring that every time it was determined that there was a standard of care violation, there was some type of compensation offer made. And there were various reasons why this didn't always occur. One big reason is that sometimes the insurer didn't share the hospital's view of the case or would be considering other factors in deciding whether to make a settlement offer. And in many other cases, they were so effective with the communication that they felt there wasn't a need to follow up with compensation because the patient seemed happy, seemed satisfied with the apology, and there was just little appetite for proactively offering to compensate before the patient had asked. But we did see a significant increase in the openness in terms of risk managers creating space in the conversation for patients to make that ask. So whereas typically they might give an explanation and then be silent, at least in most programs they would ask, is there anything more I can do for you? Is there anything more that you're looking for? What do we need to do to help you have resolution around this event? There were other challenges that were encountered in implementation. One is just a reluctance on the part of some institutions to jump in once they had set up this program to find that first case and get started. And as a result, in some of the projects, we didn't see many cases go through this approach. And some of the institutions struggled more than others to win over physicians. You know, there are a lot of fears that if you offer a patient a modest amount of money, they're going to run out and sue and seek a great deal more money, or that participation in disclosure will eventually lead to more reports to the National Practitioner Data Bank. And institutions had to work hard to dispel those kinds of fears. And then uniformly, we found across institutions that tried this great surprise about how much work is actually involved. This sounds like such a simple idea. It sounds like what they do all the time, but there's a big difference between doing this in the cases you know you're going to pay on anyway and doing it every time you know that there has been a standard of care deviation. And then finally, it's particularly complex to do this in situations where a hospital and an external insurance company have to collaborate to resolve a claim. For example, where you have a community obstetrician practicing at a hospital and they have separate insurance. Getting one organization to fully buy into this philosophy is hard. Getting two to fully buy in and then really work collaboratively and trust one another really takes a very deep commitment and a willingness to take a leap of faith. So that's what we've learned. I think there's a great deal more we need to learn. I view these data as less happy than we would have liked, but still promising. To me, they demonstrate that institutions that have a deep commitment to adequately resourcing this program and working together and following a principled approach will succeed. Institutions that have a less deep commitment or less ability to resource the program will not.
So playing off of that, Tom, given the data, which seems basically positive in gradations of positivity, why isn't there greater adoption?
I think until recently, there's been a relative paucity of best practices, and especially best practices that can be adapted to a variety of care delivery settings. So best practices that work not only in a large academic health center, but in a multi-specialty physician group or a long-term care setting. Those best practices are starting to emerge. But that's been one important barrier, and then the support to understand how do you take those best practices and actually implement them successfully.
Yeah. And Michelle, you alluded that there's more research that needs to be done. What's the number one unanswered question currently?
To me, it is what is the experience like for patients? We hear a lot about success stories where the institution has really succeeded in building a trusting relationship with patients and resolving it. But how representative are these studies? I've often been surprised at the reluctance of many institutions to open themselves up to a survey or some other means of systematically assessing the patient's experience. We've just started doing that for the first time at the University of Michigan and now at hospitals in Massachusetts. So I'm very excited to learn what this program feels like to most or all the patients going through it.
And Leilani, thoughts on that?
Well, it's interesting that, again, it's a transparency, yes, we're doing this program, and yes, everyone loves it, right? Where to your point, what is the patient's perspective? What are we surveying them? And also, there's probably an opportunity to get a lot better if we were having those conversations and being completely transparent through the entire process, that we could be learning and making it better.
Do something.
I would love that.
Thank you. Let me move to our final polling question, which looks to the challenges, and you've heard many, about implementation of a CRP program. So what is the biggest barrier at your organization for implementing a CRP? It appears that perception that it may not be needed or lack of know-how rank highly in the barrier realm. Tom, are these barriers insurmountable, or can successful implementation be achieved in the face of these barriers? What are the myths and the realities?
Well, I've been working in this field, pretty much full-time for over a decade, and I would say I'm more excited than I ever been about the potential for a future where communication and resolution programs that are highly functioning are really the norm, not the exception. But to get to that reality, we're going to have to really confront, I think, 4 critical myths that are influencing and impeding our progress so far. One myth is that communication and resolution programs are mostly about disclosing and offering compensation following serious medical errors. It makes sense where this myth came from, because in the field for the beginning, we really were talking about when something goes wrong, what do you say to the patient? And then folks realized, well, that's not quite enough. We need to think about not only what do we say to the patient, but should we be offering them compensation? And so for a while, these programs were called disclosure and offer programs, or disclosure, apology, and offer programs. And these, in fact, are really systematic, top-to-bottom initiatives that affect a whole range of quality and safety activities, not just what do we say to the patient and do we offer them compensation. There's actually a second myth built into this question. Lots of people have thought that CRPs just are applicable when there's been a serious medical error. And as Michelle hinted at, these programs are applicable anytime there's been an unexpected adverse outcome in healthcare, some of which are due to medical error and some of which are not. I think the most important myth that we need to understand and overcome is this notion that CRPs are a risk and claims management strategy. And Elaine, no offense to my colleagues in risk management who are a critical part of this process, the organizations that have made the most progress in implementing CRPs are ones that have recognized that they really are quality and safety activities that have a risk management benefit. But the fundamental reason for doing this is to improve not only the experiences of the patient who had an unanticipated outcome, but to learn from those events and to keep them happening in the future. Organizations have been doing a very careful job of selecting which cases the CRP approach should be used in. And this is also a fundamental misconception. One of the biggest challenges we're noticing in the field is the selective implementation. Rick Boothman, who Michelle talked about, highlights this as a principled approach. And for this to work, you really need to apply it every single time there is an unanticipated outcome. If you pick and choose the cases, it may make sense from a claims management perspective, but you lose all the quality and safety benefits. So it's critical that folks really think of this as a principled, comprehensive approach and not pick and choose what cases make the most sense. And then lastly, this is sort of both a myth and I would say kind of an excuse. You know, we hear from lots of folks, well, this is only possible in a state environment where strong tort reform is in place. And I'll tell you, of all the states that we've been to, just about every one of them feels like they're sort of in a uniquely challenging environment as it relates to liability. And I think basically we just need to get over it. Organizations that have implemented CRPs successfully have done so in a wide variety of tort environments. There are lots of things that state legislators can do to create a more supportive environment, but much more important than the tort environment is the institutional commitment to move forward. So if we can understand these four myths and develop strategies for overcoming them, I think that future where high-functioning CRPs is the norm is for the first time really within reach.
So specifically to the perceived myth that you need to be a well-developed health system to engage in this process, you mentioned briefly that this is applicable to ambulatory care centers, to long-term care facilities. I'm wondering if, Michelle, you have any comments about, is there additional challenge to that?
I think there is in most cases, and it has to do with resources. So the advantage, one advantage that hospitals have is that they are more likely to have a very robust risk and claims management function going on. Whereas some of the multi-specialty physician clinics, for example, that Tom and I have worked with, they've got a 1 FTE risk management office, and they don't just do med-mal, they do everything. So to pile this on with the additional work involved in arranging and conducting communications and in doing additional investigations and spending more time on resolution, in that context is really challenging. There's nothing inherently different about those facilities that makes it impossible to carry this out, but I think one has to be realistic about the resources that any facility has and the extra work involved.
Thank you. Tom, moving on, best practices to sort of help with these myths or implementation issues?
Well, from our experiences with implementation in a variety of settings, I would pull out, I think, 5 key lessons. The first is that implementing a CRP is a sprint followed by what I would characterize as an ultra marathon. This is a difficult, resource-intensive process that requires continuous attention and making sure the right people and commitments are in place. It's difficult to implement a CRP program while you're also upgrading your electronic health record or pursuing some other major systemic initiative. Interestingly, CRPs are a very good fit with the work organizations are doing around high reliability, and so it does pair with some of these major initiatives. But it really, you have to see this as a long-term commitment. Nobody is going to stand up at a healthcare institution that's thinking about implementing a CRP and say, you know, I'm not so sure about telling patients the truth when something goes wrong, or I don't think it's a good idea to offer them compensation. The resistance that you encounter is much more passive. And in our experience, it often occurs kind of on the brink of implementation, is when all of a sudden you start to get the sense that some of the folks that you thought were on board, some of the key stakeholders, all of a sudden are really not so sure that we're quite ready for this. And then even when you sort of go live with the program, you can hear this litany of, well, this is not such a good case. Maybe the next case, you know, well, that one's not such a good case for this approach either. And so you have to really do a search and destroy mission for that sort of passive resistance and deal with that really right up front. Some places have tried to do this without engaging their physicians and have regretted it. Physicians, when they first hear of this concept, are somewhat anxious because they sort of feel like a lot is on the line for them. They're oftentimes the one who's the focus of a malpractice claim. They're the ones who get reported to the data bank. If a state board of medicine gets involved, it's their license that's on the line. And that is scary stuff. But the way forward is not around the physicians, but rather to really engage with them. And fortunately, when physicians really learn how this approach works and the benefits, they become the strongest supporters. But they need to be involved in this process really from the beginning. And just like you can't cherry pick the cases, you can't just do a little bit of CRP. You can't say, well, let's just focus on the communication with the patient. Or maybe we'll improve the way we do offers of compensation. It has to start with improved adverse event reporting, communication with the patient and family, adverse event analysis using human factors, resolution, quality improvement, care for the caregiver. The whole sort of spectrum needs to be happening simultaneously. The good news, and we'll talk about these in a few minutes, though, is that there are resources that are becoming available that can help organizations figure out how do we jump in and do it in a way that can work at our institution.
In follow-up to that, we often hear from colleagues, we have a full-blown disclosure program. Does that alone make a CRP?
It doesn't. That's just maybe a third of the battle, but it's a really good start. So if you have a pre-existing culture of disclosure, we have found it seems much more likely that you will succeed in creating the surrounding culture to support explanation after investigation and ultimately some type of resolution.
And Leilani, to the conversations we often have where you're like, do something if you can't develop an entire, enterprise-wide program. What other elements would be critical? As Tom mentioned, physicians, participation, other things.
So when my son died, that was 10 years ago, there was one person who was the person who consistently was speaking to me. I would send her an email and she would answer. I would call her and she would answer. And at that time, I had no idea that that was so remarkable. And now I see that that was a very remarkable thing. But the whole program did not exist at that time. The need, however, was there. So I think we can get really caught up in the thought that this is an ultra marathon, and I agree. However, sometimes doing the short sprint is where we have to get started. So what concerns me in these lessons learned is if we think we need to be immediately training for the ultra marathon, it's kind of hard to just pull on your shoes and tie them up and get started. And I would encourage anyone to just get started and use those resources, because doing nothing, I don't think it's working.
I agree with Leilani, although I would say one of the most common things that we hear when we present these concepts to organizations is, oh, we already do this. Mm-hmm. Yeah. And what they mean is they would like to be doing this, or they've done it in one or two cases in the last year. But it really is recognition of this as a systematic approach. Once they see that, I think their face gets a little sad and they realize, oh, we're actually really not doing this. And that's the first step towards beginning that journey. The tools that we're going to talk about in a minute include tools to help organizations assess their readiness to move forward in different areas and to really systematically look at the gaps that they have and then help them fill those.
Let's move to those resources, Tom, because I know that's of interest to the audience for sure.
The Agency for Healthcare Research and Quality, which is a part of the Health and Human Services that funds a lot of work in this area, is in the midst of a project to develop a large toolkit that's called CANDOR. CANDOR stands for Communication and Optimal Resolution. Several of us are involved in creating and testing that toolkit at 14 hospitals across the country. That will be coming online sometime this fall, and I think that will really be a wonderful set of resources to help organizations figure out, how do I put my shoes on and take some practical next steps. Macrame, which is a Massachusetts alliance around communication and resolution programs, has really been doing a lot of nice work to collect some of the tools that they've developed and put them on their website, which is listed on the screen here. That's a great place for people to go right now for resources and tools for moving forward in this area. And then I'm leading, along with many others in the country, a collaborative for accountability after medical injury, which is really trying to do three primary things: identify and disseminate best practices, really think through how do we create a supportive local and state and federal policy environment for these programs, and then thinking about, well, where are the innovations? How do we take these ideas and really help move them forward? So there are lots and lots of tools that are available. And, the evidence base is starting to emerge. But one of the things we're hoping that organizations that partner in this work are going to be willing to do is to start to share their data more. Perhaps we could create a registry or some way to pool data from multiple organizations to really start to understand what are some of the experiences, what are the predictors of the CRP process going well or going poorly. It would help identify those best practices, and I think it would help strengthen the case that this is sort of really should be an expectation that every organization and delivery system has a communication and resolution program in place.
Tom, you mentioned local, state, and federal policy on this topic. Michelle, Tom, any comments about what's evolving? Are there going to be public policy motivations to develop CRPs, or what are we looking at?
Well, I think we've seen quite a few already. A few states have taken the initiative to adopt or strengthen laws protecting statements of apology and explanation after medical error, which, although not necessary, is helpful sometimes in persuading physicians that it's safe to apologize. And more recently in Oregon, they've gone a step farther and actually created a program through which the state can support and facilitate mediation in the context of voluntary CRP programs.
And Tom, is there some work going on in Washington State, particularly around physician issues?
Well, at the state level, there are a number of exciting developments. CRPs coexist with state regulators like boards of medicine, which is really an important tool that the public has to oversee and monitor the quality of care. CRPs have presented a real challenge for state boards of medicine because they rely heavily on concepts of just culture and trying to understand system failure, human error, and distinguish it from cases where provider competence was the problem. And so there's a lot of exciting work going on with state boards of medicine to help them be a part of CRP processes while strengthening the tools that exist provider competence is not nearly as much of a problem as some consumer groups would suspect, but I think it's more of a problem than the profession has been willing to admit up to this point. So I see these two streams developing in tandem: public support for CRPs, but also encouragement to develop better programs to identify clinicians who are struggling and help them provide safe care.
And from a patient perspective, influence from a regulatory perspective in this process?
Again, patients probably aren't thinking about these things when they go into the hospital. So, but I do think there'll be more and more demand for transparency, and I believe that's a good thing. And so if it's regulatory influence that helps that happen, I'm okay with that.
Okay.
I think patients would be okay with that.
Let's move to some of our audience questions. So let me turn to Michelle on this one. You alluded to this during the discussion on the research findings, but do you have particular information or statistics on the reduction to liability costs through CRP?
Well, the data that I've presented in the slides, I think, are the best available data that we have so far. You know, it was difficult for us to measure this in the federally funded demonstration projects because they were 3-year projects, and that was soup to nuts. That included the design phase. And as we well know, many times these claims are not initiated until a year or 2 or even 3 after the event. So the bottom line in terms of liability exposure from those projects is still a bit of a question mark. But I will say the number of cases processed through those programs that came to litigation over the course of our study was very low. I would say less than 10% when I think about the New York study. But to me, the most compelling data still remains the data out of the institutions that did a full and robust job of implementing these programs, like University of Michigan.
So you really sort of do need a framework.
You do. You have to sort of go hard or go home, because particularly if you're seeking to demonstrate to the board that this has a positive effect on your bottom line, or at least not a negative effect, there has to be enough of a widespread application to even be able to see an impact. So, for example, just rolling this out in one clinical department can be appealing from the perspective of conserving resources and going slow, but you're not going to have statistically significant results to present to a board 3 years later because the claims experience is just too narrow.
And Tom, it's got to be pretty scary to hear, you know, the potential for national data bank reporting or discussions that are uncomfortable. Comments about that?
Well, these are not the sort of programs that you can import from the outside. There are best practices and programs that organizations can take and use, but it makes a huge difference if the chief medical officer, if a department chair, a quality or safety lead is the one who's out in front of their colleagues saying, we really think this is a good idea. It not only is good for our patients, but it's good for the quality of care that we deliver, and it's good for us as physicians. When they hear that message and start to understand what this involves from local leaders that they trust, usually the question we have from physicians is, how do I sign up, or what number do I call, or how do I take advantage of this program? But if it feels like it's a program imposed from the outside, it's less likely to develop that local sort of buy-in and trust from the physicians.
And Leilani, one of our questions from the audience is how to become a well-skilled dispute resolution professional in a CRP program. And while that may have its own set of, quirks and elements, describe a little bit about what the qualities were that were helpful to you in going through this process.
I never had the time to wonder what was happening. So the communication was consistent with me. It was early. There were not gaps. The relationship continued over an extensive period of time. Mm-hmm. So there wasn't any space for me. I honestly never thought about a legal option. And that maybe is because when you're in the state of something like that happening to you, your ability to process information is diminished. But I never was struggling for information. I never had questions. They were answered for me almost before I would have them. And if I wondered more later, which I did, I knew how to find those answers.
I'm optimistic, Elaine, that within the next 12 months, there are going to be a host of very strong training options available for individuals from organizations that want to be sort of trained in this domain. At the moment, most of the best practices are coming to the institutions themselves, but I think there are going to be opportunities in the near future for fellowship programs, internships, other sorts of training opportunities where organizations can send individuals for that type of training to really be ready to step into this role effectively.
And then one of our audience participants has a question, and you alluded to many of the points about this earlier. What type of resources, time and money and energy-wise, do these programs really take to develop in the face of, as you mentioned earlier, organizations with 1 or 0.5 risk managers?
Yeah. So, it depends on the size of the organization. It's driven by the number of adverse events to which they're going to have to respond. But we actually asked that question when we interviewed, I think at this point, close to 75 different participants who'd been involved in implementing these programs. And pretty consistently from hospitals and large clinics, the answer is somewhere between 0.5 and 1 full-time equivalents in risk management. And that person need not be a lawyer, need not be a risk manager. It could be somebody with a clinical background or a patient advocacy background, but just someone who can put boots on the ground to coordinate the parties. At about that level, the investment will pay off.
And Tom, is it imperative that risk management be the source of this program development?
Not necessarily, and this is an area where some of our respected colleagues, I think, have differences of opinion. I think Michelle, in my experience, really was that additional resources are required. But if you ask someone like Rick Boothman, who has an enormous experience in this area, his perspective is that it's about redeploying existing resources. When you're in a position like Rick is within an organization and can do that redeployment, I think you can make the case that an organization could do this without investing additional dollars. But I think relying on that model alone, I think, is less likely to be successful.
And comments about that, Leilani? Barriers? Any good reason to not go this path?
I don't believe so. If we look at the numbers and the results of Pearl that we've had it here at Stanford, there's a significant dollar savings. So if you look at it from a business case standpoint, the money that can be saved, maybe that pays for your additional person who's going to work on these programs for you.
Well, although we could talk for days on this topic, I do need to wrap it up in the interest of time. So thank you, panelists. We've had a great discussion today over a broad range of aspects associated with communication and resolution programs. If you had one key take-home point to leave with the audience, what would that be? And I'll start with you, Michelle.
So that's actually a question that we ask when we interview people who've been through this experience, and almost always the answer is try it. Even people who have really struggled with implementation challenges say it's worth doing, and they say there's 2 reasons for that. One is it likely will save money. But the other is it's the right thing to do. It's the right thing to do for patients, and it's part of discharging the institution's commitment to stand behind providers when something untoward happens.
Tom?
I think the most important take-home message from my perspective is this sounds like a daunting journey, and it really is systematic culture change for organizations, but every organization is at some point in their path of readiness. So once they make the commitment to move in this direction, all you need to do is think about how do we take that next step, rather than being daunted by the challenges of going from 0 to 100 miles an hour immediately.
And Leilani?
Adverse medical events, nobody wants them to happen. They're essentially accidents, and they happen without anyone's intention. But how we choose to respond to them, that's an opportunity for greater patient care, because we can be deliberate and we can make choices in how we respond to those accidents. And I think we should do that.
Thank you very much, panelists. This concludes our webcast for today. We would like to thank our collaborators who helped spread the word about today's webcast, including Aon Risk Solutions, the Lockton Group, Medical Protective Company, and SoriWorks, and to all those others who assisted us in spreading the word. And finally, thank you to our esteemed panel members for your participation and your ongoing important work in the CRP arena. Michelle, Leilani, Tom, thank you very much. My name is Elaine Ziemba with the Risk Authority at Stanford, and thank you very much for joining us today. We look forward to seeing you in the future.